Ready?
A 25-year-old primary gravid woman. A 25-year-old primary gravid woman, 28 weeks of gestation, has an extreme fatigue, anorexia, intermittent vomiting over the past 4 weeks. Her pregnancy had been uncomplicated. She appears pale, fungi, height is 28 cm. Her hemoglobin is 8 gram per deciliter. MCP is 105, MCHC is 25%. Hemoglobin percent. Which of the following is the most likely diagnosis?
Mm, 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 mm.
Ready?
No, give me a second. The MCHC is low. Mm. Folic acid or vitamin B12. Maybe folic acid. Okay, ready.
Okay.
It is, what am I? 41?
Yep.
41. Folic acid deficiency. Folic acid deficiency is a cause of megaloblastic anemia. Is common in pregnancy as a result of increased folic acid requirements, especially when accompanied by malnutrition. Other causes include alcohol use disorder, malabsorption, and the use of antifolate medication. The anemia is caused by impaired DNA synthesis in the red blood cell progenitor cells due to absence of required cofactors. Uh, Symptoms include fatigue, pallor, lightheadedness, and shortness of breath. Perhaps studies will show a decrease in hemoglobin concentration, increased MCV, and decreased reticulocyte count, and normal methylmalonic acid concentrations. Were white blood cell and platelet counts are generally normal. Peripheral blood will show hypersegmented neutrophils. Treatment requires folic acid supplementation and red blood cell transfusion if severe. Folic acid supplementation is important for pregnant patients as deficiency can lead to neural tube defects in fetus. This is most significant in the first trimester during initial organogenesis. It is not pernicious anemia. Vitamin B12 deficiency is a common cause of megaloblastic anemia. It's often caused by inadequate intake, seen in veganisms and malabsorption of pernicious anemia. Pernicious anemia is caused by autoantibodies against intrinsic factor, which inhibits its role in B12 absorption. Mild symptoms are likely those of folic acid deficiency. Severe deficiency can cause neurologic symptoms such as dementia, subacute combined degeneration of the spinal cord. However, B12 deficiency is less likely in pregnancy than folic acid. And it's not sickle cell autosomal disorder that is caused by mutation in globin genes, which results in abnormal hemoglobin that is prone to cycling under conditions of stress. This cycling leads to vascular occlusion with cyclic pain crisis, functional asthenia, hemolysis, anemia. This previously healthy patient is unlikely to have this. Okay, next.
A 32-year 32-year-old woman, gravid at 3 para 2 40 weeks of gestation, admitted to the hospital in labor. Her pregnancy has been uncomplicated. She has a history of 2 uncomplicated vaginal delivery. Her temperature is 37, pulse 80 per minute, blood pressure 90/60. Physical examination shows no abnormalities. Fetal heart rate is reassuring. Labor progresses normally with epidural anesthesia. When the patient is 9 cm dilated, 90% effaced, the vertex is 2 plus station, she suddenly begins gasping for air and has generalized tonic-clonic seizure. Examination shows bleeding from gums, nose, and IV sites. There is brisk red vaginal bleeding. Within a 1 minute of the beginning of the seizure, she has cardiac arrest. Which of the following is the most likely cause of this patient's symptoms?
Ready?
Yes.
So it's amniotic fluid embolus. Amniotic fluid embolism is a rare and potentially fatal complication of childbirth caused by amniotic fluid entering the maternal circulation. It most commonly occurs during delivery on in the immediate postpartum period. Typically presents with acute onset of shortness of breath, altered mental status, or unconsciousness, yeah, and bilateral wheezing. Seizures can also occur but are less common as an initial presenting sign. Signs of fetal distress can also occur if the fetus remains in uterus at the time of occurrence. Vital signs will show tachycardia, hypoxia, and severe hypotension. The patient can quickly decompensate into cardiovascular collapse and cardiopulmonary arrest. Chest X-ray may show pulmonary edema. Treatment is generally supportive, with patients often require fluids or blood products and mechanical ventilation. Complication includes diffuse bleeding from venipunctures, the vaginal C-section, incision as a result of DIC. I think that's it. That's where it stops. I don't think I was confused with another.
Okay. Next.
Wait, I was confused maybe with this part. Thromboembolism of the pulmonary artery present with shortness of breath, tachycardia, hypoxia, as well as hypertension. If the PE is massive and hemoptysis if infarction has occurred. Okay. Massive pulmonary PE can cause cardiac arrest if the obstruction is severe. However, given these patients, coagulopathies in generalized tonic seizure during labor, amniotic fluid embolism is most likely diagnosis. And it's not thrombosis of the cerebral vein has a varied clinical presentation, which includes headaches, focal neurologic seizures, and encephalopathy. Small cerebral ischemic insults can occur as a result of venous blood congestion. While pregnancy is a risk factor for cerebral venous thrombosis, it will not explain these patients' other symptoms. Okay, next.
A 61-year-old woman comes to the physician because of itchy rash on her breast. She noticed 6 months ago. She says the rash began small area flesh-colored bumps. Intermittently felt irritated. Since then, the rash appeared spread, become scaly. She uses powder in the brush because she tends to perspire. She has begun using different soap. Neither effort has provided relief. She has 20-year history of hypertension, 5-year history of type 2 diabetes mellitus, 59-year history of eczema. Her medications are valsartan and metformin. Vital signs are within normal limit. A photograph of the left breast is shown. The remainder of the examination shows no abnormal. Which of the following is the most appropriate next step in the management?
Ready?
Ready?
Yeah. Okay, so it is tissue biopsy. Paget disease of the breast refers to, yeah. refers to unilateral eczema-like patches of the nipple and areola that are associated with underlying ductal carcinoma in situ or invasive carcinoma of the breast. It's widely accepted that patchy disease represents an external manifestation of of underlying malignancy, though it's a much less common. I cannot read the other part. Particularly when the relatives are premenopausal at diagnosis, greatly increases the risk. Diagnosis of Paget disease and or underlying malignancy is confirmed with biopsy followed by appropriate next steps if an underlying malignancy is found. Treatment depends on the presence of malignancy and its stage, but may include surgical resection, chemo, radiation. It's not MRI of the left breast may be beneficial in determining if there is underlying malignancy, while mammogram is more commonly used to evaluate patients who present with patent disease of the breast. MRI is more sensitive, is a more sensitive imaging modality. Okay, however, MRI will not clearly diagnose this presentation as Paget disease of the breast, making it less appropriate next step in management than tissue biopsy. Okay, doesn't make sense, but okay, next.
An 80-year-old nursing home resident is brought to the physician because of perineal bleeding 2 weeks. She reports that she has had something falling out of her vagina 10 years ago. For 10 years, a 10 is to 6 centimeter mass, a 1 centimeter ulcer on the dependent portion of the protruding area of the vagina. Which of the following is the most likely cause? Really?
Yeah. Okay, so the answer is complete prosidential. Pelvic organ prolapse occurs secondary to pelvic floor dysfunction and weakness, so resulting in herniation of abdominal pelvic organs, which cause mass effect and protrusion along the vaginal wall. Complete presidency is a severe form of POP, pelvic organ prolapse, that includes herniation of the entire anterior, posterior, and apical vaginal compartment through the intuitus, such that the patient has a degree of cystocele bladder prolapse, rectocele rectal prolapse, and enterocele intestinal prolapse caused by the descent of the pelvic organs. Additionally, all or a portion of the cervix and uterus may be visible externally at the introitus in incomplete presidential. POP is more common in individuals who have had multiple childbirths, advanced age, obesity, all of which are risk factors. These pelvic organ herniations can result in urinary defecatory sexual dysfunction depending on the extent of herniation. Other symptoms can include an external mass that may show ulceration and bleeding as found in this patient. Diagnosis is made with complete physical exam. Treatment includes pelvic floor exercises, vaginal pessary, and surgical correction. It is not the vaginal myoma. It's a benign tumor on the vaginal wall that may present with a palpable mass and vaginal bleeding as found in this patient. However, these tumors are extraordinarily rare, and complete prosidential will be most likely in this patient. Okay, next.
A 16-year-old girl comes to the office. She has not had a menstrual period in 2 months. Mens previously occurred at regular 30 days intervals. 1 month ago, she was diagnosed with rubella, and the symptom resolved spontaneously. She has no history of severe illness, takes no medication. She is sexually active with one male partner. They use condoms inconsistently. Vital signs are within normal limit. Examination show a uterus consistent in size. With 11 weeks of gestation, a urinary pregnancy Urine pregnancy test is positive. The fetus is greatest risk of which of the following cardiac disorder? Oh, PTA. Okay.
Okay, so the answer is PDA. Congenital rubella. Do we need to read this one? We know
Yes.
rubella with. Okay, I'll read it. Congenital rubella presents with
Next,
the classic. Okay, I thought you meant I had. Okay,
we know that congenital rubella is PTA deafness and cat.
okay.
Okay.
Hmm.
Next, a 46-year-old woman gravid to para 2 comes to the office because of 3-month history of painless vaginal bleeding that has required the use of the sanitary pad tampon. Menarche was at age 13 years, means 24 to 32 day interval. She has no history of serious illness, takes no medication. Her mother was diagnosed with breast cancer at the age of 68 years. Vital signs are within normal limits. Pelvic examinations show mildly enlarged uterus. There is blood from the cervical os. The remainder of the examination shows no abnormality. Which of the following is the most appropriate step in the management?
Ready?
Okay,
Okay. So it is endometrial biopsy. Okay. Abnormal uterine bleeding should be suspected when bleeding is irregular, unpredictable, or not associated with signs of menstruation. It may be caused by malignancy, structural abnormalities, adenomyosis, endometrial hyperplasia, inflammation, infection, coagulopathy, ovulatory dysfunction, endocrine dysfunction, or maybe idiopathic. In patients over 45 who are perimenopausal or postmenopausal, there is a high risk of hyperplasia and cancer. Endometrial cancer commonly presents with postmenopausal vaginal bleeding. As in this patient, risk factors include prolonged unopposed exposure to estrogen such as early menarche, late menopause, chronic and ovulate PCOS, exogenous estrogen therapy, nulliparity, obesity. The most appropriate next step is endometrial biopsy to evaluate for presence of endometrial cancer. If a patient cannot tolerate the procedure, if the procedure is not diagnostic, dilation and curettage or hysterectomy can be performed. Okay. It's not a combination of CPs is an effective method of contraception that may also be used to treat abnormal uterine bleeding secondary to ovulation, such as seen in PCOS. Oral contraceptives may also be of benefit in the treatment of primary dysmenorrhea and menorrhagia. CPs. Yeah. However, this patient is perimenopausal and has prolonged uterine bleeding, which will prompt evaluation for cancer. And it's not hysteroscopy is frequently used to evaluate for the uterus for structural causes of irregular menstruation, as it can visualize the entire endometrial cavity. This makes it useful for diagnosis of polyps and fibroids. Hysteroscopy can also be used to obtain endometrial biopsy, but it's more invasive option. Okay, next.
32-year-old woman, 32-year-old woman gravid to para 1, 10 weeks of gestation comes for her first prenatal visit. She delivered She delivered her last child 9 months ago. The pregnancy was complicated by deep vein thrombosis of the left lower extremity, documented by venous Doppler ultrasonography. Her mother and sister also had DVT during pregnancy. Her maternal grandfather and uncle died of cerebral infarction in their 40s. Examination shows a uterus consistent in size of 10 weeks of gestation. Which of the following is the most appropriate screen?
Ready?
Yes.
Okay. So it's factor 5 Leiden mutation analysis. Factor 5 Leiden is autosomal dominant where coagulation factor 5 is resistant to inactivation by protein C, leading to hypercoagular mistake caused by a point mutation in the whatever, F5 gene of factor 5. It is the most common inherited cause of hypercoagulability in white patients. Pregnancy causes hypercoagulable state due to the overexpression of coagulation factors, all of them, the underexpression of anticoagulant protein S, and venous stasis in the pelvis and lower extremity caused by hormonal changes and compression by the gravid uterus. Thromboembolic events during pregnancy or postpartum period are therefore a common presentation of factor 5 Leiden, as these patients are already predisposed to such events. Other presentations include thromboembolic events within the uteroplacental arteries, leading to placental infarct and possible uterine death, intrauterine fetal death, and cerebral vein thrombosis. Uh, Heritable coagulation disorder should be suspected in this patient with a history of provoked DVT in combination with extensive family history of thromboembolic events. Diagnosis can be confirmed with genetic testing or a functional assay evaluating activated protein C resistance. Venous thromboembolic events prophylaxis with low molecular weight heparin is indicated for gravid patients with factor 5 Leiden um, and personal history of thromboembolism. Warfarin is a teratogen and should be avoided. Novel oral anticoagulants such as rivaroxaban and apixaban are not recommended because of fetal safety concerns. It's not a measurement of plasma fibrinogen concentration is often indicated in evaluation of coagulopathy. It will be decreased in consumptive coagulopathy such as DIC coagulopathy and normal in common clotting factor deficiency such as hemophilia A or B. Okay. Fibrinogen is among the clotting factors overexpressed in pregnancy, leading to hypercoagulable state. But acquired hyperfibrinogemia will not explain this patient extensive family history of venous of DVT. Okay.
Next.
Mhm.
A healthy 27-year-old woman gravid to para 1 24 weeks of gestation comes for a routine prenatal visit. Pregnancy has been uncomplicated. She feels well and she feels well and her fetal movement has been appropriate. Her blood group is ARH positive. Her only medication is multivitamin. At her first prenatal visit, her hemoglobin concentration was 11.2. Rubella testing showed immunity, hepatitis, and HIV antibodies were negative. Urine culture and testing for Neisseria gonorrhea and chlamydia trachomatis were negative. A pap smear showed no abnormality. Ultrasonogram 1 month history show fetus consistent in size of 20 weeks of gestation. Examination today shows a urine fundus measuring 25 centimeter symphysis to the fundus. The fetal heart rate is 155. Urine analysis is normal. Which of the following is appropriate? indication for this visit. Is it OGTT?
Mm, in between that and repeat ultrasound. But okay, let's see. So yeah, it's OGTT. 1 hour maternal glucose tolerance test is typically performed between 24 to 28 weeks of gestation or pregnancy to screen for diabetes. However, this test can be done at the first prenatal visit if there is suspicion of underlying or pre-existing diabetes, or in patients who have a BMI greater than or equal to 25, in addition to another risk factor such as first degree relative with diabetes, hypertension, previous macrosomia or gestational diabetes, or a history of impaired glucose tolerance. Gestational or pre-existing diabetes can lead to increased risk for congenital anomalies. Spontaneous abortion is stillbirth, microsomia, shoulder dystocia, all of that. Neonatal effects of diabetes can include hypoglycemia, caused by sudden change in maternal fetal glucose balance, hyperbilirubinemia, polycythemia, and an increased risk of NRDS. Therefore, the early recognition of both gestational diabetes and pre-existing diabetes allows for the initiation of appropriate treatment, decrease average blood glucose concentration, and improve neonatal outcome. It's not if repeat ultrasound is not yet indicated for this patient in her second trimester with a normal 20-week ultrasound routinely performed for anatomic survey and growth monitoring. Further routine ultrasound is not recommended until the patient reaches 28 weeks gestation or later. These scans are used to monitor fetal growth and amniotic fluid index. Okay, next.
A 15-year-old girl is examined at juvenile detention. A 15-year-old girl is examined at juvenile detention facility clinic for an inmate health examination. She has no history of serious illness, takes no medication. Immunizations are up to date. She was sexually active with one male partner 3 months ago. They use condom inconsistently. Vital signs are within normal limit. She is at 90 percentile for height, 70 percentile for weight. Examination show no abnormality. Which of the following is the most appropriate next step for this patient?
Okay, ready?
Yes.
So, testing for chlamydia and Neisseria. Testing for chlamydia and Neisseria is recommended by USPS, whatever, for all sexually active patients under 25. Chlamydia is a STI that classically presents with urethritis, dysuria, dyspareunia, and urethrovaginal discharge. Gonorrhea is a STI that presents most commonly with mucopurulent discharge and pruritus. However, both infection can also be asymptomatic. That's why the screening. Complications include cervicitis, PID, bovarian ulcer, long-term issues with fertility. Diagnosis is made with NAT. Treatment consists of azithromycin, doxycycline, and ceftriaxone. It is not A or C. Hep B surface antigen and Hep B surface antibody assay are useful in the diagnosis of active Hep B infection, which is a blood-borne infection. Acute Hep B presents with fever, abdominal pain, nausea, vomiting, and anorexia and jaundice, while Hep B surface antibodies are present in those vaccinated against Hep B and those infected with Hep B. Hep B surface antigen is only positive in those that have an acute or chronic infection. Asymptomatic screening for infection is not recommended for patients who are vaccinated, such as this patient. How do you know she's vaccinated? Oh, immunizations are up to date. It's not C. PASME refers to evaluation of cells of the cervix as a screening modality for cervical cancer. It's recommended to start at 21 and repeated every 3 years. So it's 21 every 2 years. After 30, it can be repeated every 5 years if it's done with HPV testing. Okay. What am I? This patient is 15. Those parts male is not indicated. Okay.
Okay.
Mm-hmm.
Okay. Final question. A 20-year-old woman, gravida 1, para 1, comes to the physician because of vaginal discharge since an uncomplicated vaginal delivery of her newborn at term 1 week ago. Initially, the discharge was red, but it is now white. She is breastfeeding without difficulty. Temperature is 37. Physical examination show no abnormality. Thick white physical examination. Pelvic examination show thick white vaginal discharge. No vaginal laceration are noted. Cervix is closed. Uterus is consistent with 12 weeks of gestation. Which of the following is the most likely diagnosis?
Ready?
Yes.
Okay. It is lochia alba. Vaginal discharge following delivery is termed lochia and may last during the period of the puerperium for 4 to 6 weeks. For 4 to 6 weeks. It is caused by shedding of the superficial residue and progresses through 3 stages. The early stage is rubra, contains blood and may last 10 days. Lochia slowly becomes less bloody and more serous. Lochia serosa, approximately 2 to 3 weeks before finally becoming white or yellow. Lochia alba. Physical exam, lab studies, and everything are normal. Um, as Lochia is physiologic than rather than pathologic. It is not candida, it's caused by overgrowth or normal vaginal candida. It presents with vaginal pruritus, vulvar redness, and thick white discharge with normal pH and negative KOH testing. Risk factors include diabetes, recent antibiotic, steroid use. While this patient has white vaginal discharge, he has not the symptoms that suggest candidiasis. Okay, we are done.
Okay. We can stop today.